Fake news stops here. This is my new mug from the Texan. And for those of you who would like to have a mug like mine, you can go to the Texan.news and subscribe sometime before the end of the year. And you're going to get one of these super cool mugs that will make all your friends and your family jealous, and it'll be awesome. That goes into today's conversation because I got to sit down with Brad Johnson, and he is a reporter at the Texan, and he did an in-depth article series on healthcare in Texas. 3 different pieces, each like 2,000 words. So if you actually want to read 6,000 words like I did regarding our healthcare policy and healthcare in Texas, you can go to the Texan.news. But you could also just take the next 45 minutes and listen to my conversation with Brad so you can get an update for yourself. It's a little, I guess, it's maybe a little bit more entertaining route to go for those of you who would rather listen or watch this than you would go on and read. But I've been a big fan of the Texan from the beginning and been telling you all about them. And so I read this series of articles and thought it'd be a really good conversation to bring to you. Also wanted to give you a quick update before we get to that conversation. If you go to LukeMacias.com, we updated a story over the weekend that James Younger, the young boy who is being transitioned to be a girl by his mother at the age of 7, due to a Dallas County judge forcing the recusal of the other Democrat Dallas County judge who ruled in favor of James and Jeff when she granted Jeff joint conservatorship, thereby giving him veto authority over the puberty blocking suppressants of his son. So that's happened. That judge was recused, and now as a result of that, a Republican judge, Ray Wheelis, who's the administrative judge over the whole region, now has the case in his hands. And what that means is he's going to assign it to a different judge. So I did a little bit of digging, talked to a couple attorneys, and my understanding is that basically Ray has the ability to assign this to the appointed Republican judge by Greg Abbott in Dallas County. He could actually take a sitting judge from another county outside of Dallas County, a Republican judge, and actually let them come into the court in Dallas County and preside. So he's got a lot of latitude regarding how he handles this case. And so we just brought that story to you. Go to LukeMacias.com, share that story with your friends, especially in the DFW area. We're very hopeful that Ray will, do the right thing here, but wanted to make sure that story was brought to your attention. So you can go to Facebook or our website to read that story and share it with your friends. And without further ado, I want to get directly to the conversation with Brad Johnson. Well, I am joined, episode 46 of the Luke Macias Show, by a reporter at the Texan, Brad Johnson. Thank you for sitting down with me today, Brad.
Thanks for having me, Luke.
How has your introductory time to Texas gone so far?
Took a little bit to get used to the heat. I'm a Yankee.
There you
I'm
go.
from Ohio, so
Okay.
This summer was a bit rough,
Yes.
but thankfully this is now my kind of weather.
Had you ever been in this much heat before you came to Texas? Or had you spent
I've
time?
been to Disney World a couple times,
Okay,
and
yeah.
so one was in the summer, so that was hot,
Yeah.
but I'd actually never been to Texas before I moved here.
I know we're both wearing vests
Yeah.
right now, and I feel like we're in that weather where it's like I put this on every day hoping that I get outside and don't feel like taking it off.
Yeah.
Today is like that day where I'm like, probably don't need to wear this, but I'm going to wear it as like a hope
Yes.
of bringing colder weather into our community.
Yeah, I mean, if I were in Ohio right now and not working, I probably would be wearing shorts. This is
Yeah.
very nice weather right now.
There you go.
Nothing to complain about.
So I brought you on to talk about a series of articles you have done on healthcare in Texas, right?
Yes.
So healthcare is an issue and policy that gets a lot of discussion,
Right.
And
And rightly so, because it's such a complex and frankly important topic.
Yep. I was recently had a longer conversation with a friend of mine who works in the healthcare industry, Baylor Scott and White, and he just started digging into different complexities of the system and even opened my eyes to new ideas and situations I hadn't considered before, right? So I feel like these series you've done, I know a lot of people are not as likely to read, 2,000 word articles as they are to read 200 word articles, but I did want to have you in to really dig into these 3 parts.
Yep.
And people can read the entirety of them at the Texan, which is who you write for. You see our little mugs here, right here. So I'm just going to, before we get into the long policy discussion, remind people, for those of you on the video, that you may get this mug. It says fake news stops here. And if you go to the Texan.news and you sign up to subscribe before the end of the year, they are giving you these mugs. So they will send you this mug and you can tick off any liberal journalist that you have over to your house or, I don't know, at your place of business. I'm sure they will not enjoy it. So
It'll also make a good stocking stuffer.
Great stocking stuffer. This is mine. I'm taking this home with me. I bought it. So, you can't have this one, but you can have others. So let's talk about healthcare in Texas. So the first part, you did a 3-part series, right? And they're very long articles. I'm just letting people know that for showing up. But if you're somebody who's interested in healthcare policy and you're in Texas or even in another state, to be honest, this is probably worth the read. So let's kind of take them piece by piece. Right. Your first piece was titled, The Status of Healthcare. Many uninsured Texans choose not to purchase insurance. So kind of from the top, why don't you go through some of the numbers of where Texas is at and, what your piece brought to light.
Yeah, well, first of all, the whole idea for this started when the Census Bureau released their uninsured estimates in September.
Yep.
There was a lot of media reaction, typical mainstream media reaction, hyper-focusing on the uninsured number. Now, it's certainly something to take into account, but they didn't really delve that deep into why it's like that. First of all, the rate that the Census Bureau found was, for Texas, 17.7%. That leads the nation. It actually went up from the year before 0.5%. The national average was 8.9%. So Texas was almost double.
Yep. So typical states, about 1 out of 10, a little less than that, of people are basically uninsured within that state. And in Texas, it's particularly high.
Right.
Yeah.
Correct.
And so why is that?
Well, to figure that out, you have to delve a bit deeper into the details. So the Kaiser Foundation, they kind of parse things out somewhat detailed. Now, it's not as detailed as you could possibly get, and there's also gaps in what data is collected.
Okay.
But they take their numbers from the Census Bureau.
Okay.
But their numbers based on the year before, it amounted to, there were 12% of the uninsured population in the overall gap, or in the overall population for Texas, were in what's called the Medicaid gap. Meaning, if Texas were to expand Medicaid, which they're one of the states that hasn't yet, these people would be eligible.
Okay.
And I'm going to pull up the income numbers. It's based on income and the federal poverty level.
Yep.
So if they were to expand Medicaid in Texas, people making $17,236.20 a year would now be eligible. That's about $5,000 more than currently are eligible.
Yeah. Now, when I first looked at that, I thought of like a family making 17, but I think you pointed out
that's
that
individual.
Like a family of 4 making 35 to 36,000 is kind of where that level is,
Correct.
right? So
Absolutely.
essentially, Medicaid expansion says we're taking the current population that is eligible and increasing the amount of people that are eligible, right? So we're taking people that make a little bit more than the current line that is set and saying that you too are able to apply for Medicaid.
Correct.
So 12% of our uninsured people are people who, if we expanded Medicaid, could theoretically then qualify for Medicaid, or are they people that currently qualify for Medicaid?
They would be people that would qualify once the expansion happens.
Okay. Yes. So meaning currently Texas has not expanded Medicaid.
Correct.
If they did, these 12% would then get that.
Correct. Yep.
So I saw there was 35% were eligible for subsidies but had not enrolled.
Yes. So that's a mix of a couple different types of people.
Yep.
Part of it is just people that choose not to have insurance, and that's a growing trend among individuals like yourself. You're part of a cost-sharing ministry.
Yep.
They don't want to deal with the bureaucracy, the red tape, all that stuff, and frankly, the high premiums that come along with the current mainstream insurance market.
Yep.
And Obamacare has complicated that even further. Another part of it is No, actually. So the next stat would be 38% are ineligible entirely.
Yeah.
And this is part of the overall uninsured population.
Yep.
And that can be parsed out into a couple different things. One of them, which is a significant contributor to it, people that are 400% above the federal poverty level.
Got it. Yes.
And so that means they're making incomes that are significantly higher from the FPL, but too high to be getting the subsidies.
Yep.
The tax credits or the just flat out Medicaid pay for their bills. Another aspect of it is illegal immigrants.
Mm-hmm.
There were I think it was 575,000. I'm trying to find the number here.
Yeah, and I think
759,000. Sorry to cut you off, but out of the 4,700,000 roughly people in the 2017 numbers in Texas that were uninsured, about 800,000 of those were illegal immigrants.
Yep. And so that's like 1 in 5 that I read in the article? Or?
Close to 16%.
Yeah. Yeah. So 16% of this number of people that are uninsured now, and that's actually an interesting statistic to kind of roll back on, because one of the reasons Texas would have a higher uninsured rate than that of other states is that we are directly adjacent to Mexico, right?
Correct.
So
Yes.
one would have to assume that more illegal immigrants who cross the border from Mexico don't actually make it out of Texas, right? They actually stay within the Lone Star State, and then they add to our uninsured number.
And because they're not citizens, they're ineligible for the exchange.
Yep. And so then there was I read somewhere in this article that it said 35% are eligible for subsidies, but they haven't enrolled, right? So these are not people that are eligible for Medicaid, but they're eligible for subsidies.
Correct.
So we have 12% that basically would be eligible for Medicaid if we expanded. We have 35% that are eligible currently for subsidies, something that would give them a little less as far as a payment goes on their insurance. And then you have another bigger group of people who are both slightly wealthier individuals, right? And these aren't wealthy people, right? I mean, in order to be 400% above the poverty line sounds like you're rolling in dough, but that doesn't necessarily require you to be.
I think I calculated it out. It was around 50,000.
Yeah,
I think it was just shy of that.
Yeah. So for a single individual,
correct?
Right?
Yes.
Yeah. So if you're a single guy making $55,000 a year, you fall within. You're not going to get any subsidies on your health care. You're and you've decided not to insure yourself.
And I actually calculated this out a little bit more. If you were 399% above the federal poverty level, you would be spending on healthcare averages $6,200 less than that person just 1% above you at 400.
Yep.
That's a big gap. That's a big amount of money, and relatively, they're not making that much money, and so $6,000 is a lot to ask.
Yep. So you have a group of people that have said, look, making $50,000-$60,000 a year, it's just not worth it for me to be insured. You have the 16% of the population that are illegal immigrants who are ineligible, to actually get insurance. And then you have these different other buckets that kind of break it down. So that takes the whopping 18% of Texans don't have health insurance and kind of breaks it down into a realistic understanding of the type of population we're dealing with. These are bucketed. These are some middle-class people who don't get subsidized at all, who are really making a decision on exactly what they want to spend money on or not, and are saying this is just not worth, the juice is not worth the squeeze. And then you have some people who are eligible for the subsidies, could get significantly lower health care than that of somebody making a little bit more than them, but have just decided to still not enroll on the Obamacare exchanges.
Right.
And then you have a group of people that, some would argue, well, these people would be on Medicaid if we'd expand Medicaid in Texas. So 12% of that could get taken if we would just do that.
It's important to note, though, that Medicaid's also optional. You don't have to opt into it. And so not the entire portion of that population would not join. Now maybe a large percent would, but not all of them.
And I mean, just this conversation is about health care, not health insurance, right? And I know a little bit of your pieces get into that, but just it's always important to remember that just because somebody has an insurance card, and I think you write that somewhere here, where you go, people are more more worried about whether they have access to healthcare than whether they actually have that card that says they're insured,
Yes.
right? Because Americans do not correlate one with the other.
Right.
And I think that's rightfully so, right? Because they've probably experienced too often that this card does not mean I
Yes.
get health
Yes.
insurance or health care that I actually
But I
want.
think when it comes to lawmaking, the two are conflated.
Yeah.
They're put into the same box, and that relinquishes a lot of aspects of the problem that are otherwise not addressed.
Yep.
And to go back to the uninsured rate, Texas has historically had a high uninsured rate. Frankly, where we are right now, it's between 5 and 10% less than where we were for most of the years since 1987.
Yep.
And part of the reason that the drop happened, and that happened in 2010, 2011, 2013, was it became illegal, essentially, to be uninsured.
Yes.
You had to pay a penalty
Yep.
to enroll in, if you didn't want to enroll in
Yep.
the Obamacare exchange.
Yeah, I think I paid 1 year of penalties when that first got enacted, and because I only had insurance for like 3 or 4 of those months. I didn't have insurance. I had Samaritan's Ministry, the cost sharing nonprofit that I'm involved in, but it qualified right at the tail end of the year, so I had to pay per month or whatever
Right.
that I was uninsured for that year. And I did the math, and I was like, I'm definitely getting this. I definitely have this because it's going to cost me more in paying to the federal government than it would be to have it.
And a lot of people made that decision.
Yeah.
You weren't even close to the only one.
Yeah. And so when we get into why we have higher uninsured than other people, one of the things that your first piece also gets into is, first of all, what is the cost to insuring more people? For the state to really insure more
Yes.
people, right? So I want to dig a little bit into that because, one of the takeaways is, these 12% of people that could be insured under Medicaid expansion or any of these other programs, you just make it happen, snap your fingers, and there we go. We got these people covered.
And I think it's
now.
important to emphasize that is 12%.
Yes, a small portion.
Yes, we are letting 12% of the population drive the entire discussion.
And let me understand, this is 12% of the population of the uninsured.
Of the uninsured,
yeah.
yes.
So not 12% of the population,
Right.
but this is actually
A subset
like
of a subset.
2.2% of the population, right? That are uninsured that would be insured. But you also kind of get into the cost of Medicaid to these different states, right? And the fact that it's also increasing when it comes to its overall share here in Texas. But if I read here, it says some expansion states like neighboring Louisiana have seen costs to taxpayers and state governments double from initial claims. In 2015, Louisiana estimated spending for that state's Medicaid expansion would total around $1.3 billion. Last year, that cost was an eye-popping $3.1 billion.
And a big part of those cost discrepancies were the amount of people that enrolled higher than the original projections.
Yep.
And we saw that happen nationwide.
Yep.
I think it was 61% higher projections the CBO report found of people enrolling in Medicaid than were originally projected.
Yeah. So basically saying if you open it up to this population, more of them than you think will actually jump
Yes.
onto Medicaid.
Yes.
And then we'll start using Medicaid, and then therefore will cost the state billions. And $3 billion for little old Louisiana, which,
Right.
I think is smaller than, I don't know, Harris County might even have more population than Louisiana. It's
possible, yeah.
It's possible. I don't, somebody's going to fact check me and get me bad. But the point is that, Louisiana's a very small state in comparison to the state of Texas. So if you want to take that and compare it to here, you could be looking at, well over $10 billion easily of increased cost to our state budget if we were to say, hey, let's start covering another 2.2% and potentially more of the population. So I know that is now the Brookings Institute you mentioned when they got in their argument essentially, and this is what I read, that the feds in Louisiana cover like 63% of Medicaid, right? So basically, if you look at the overall cost of Medicaid, about 60+% of that's covered by the federal government. But the Brookings Institute and some other more left-leaning organizations basically said, when it comes to the expansion dollars, the federal government is saying we'll cover 90% of the expansion,
Right.
Right. And so that's kind of the carrot at the end of the stick. Oh, don't worry, we'll actually,
Right.
love doing. I know one of the things Connie Burton, who runs the Texan, this is her, entity, loves saying is that that's still our money. So she always likes to point out, people go, well, they're going to cover 90%. No, you're going to cover 90% just a different way, or your grandkids or somebody else.
Right.
But the advocates for expansion say, hey, the federal government's going to cover right now 90% of that expansion. So if you expand to this, it's okay because the feds are going to write a check and it will get more money into your state, right, at the end of the day. Now, that is not, my understanding is that 90% is not set in stone, right? I mean, meaning it can change, the federal government can change it at any time. And from a financial commitment, the federal government's likely, and you get into this a little bit, where they're not really in a great place when it comes to the financial solvency of Medicaid, right? So one would assume that at some point we are likely to, in the next potentially 10 years, see them go, hey, that 90% we were covering, it's going to be a little less than 90%.
Yeah, I think it's 2026. It's projected to be financially insolvent.
Yep. So basically,
not too far away.
Advocates are saying expand Medicaid because the federal government's going to cover 90% of it. But this is a federal government who is going to be insolvent within this Medicaid program by 2026. And so my prediction, and it would be that probably around that time is when you're going to start seeing some of these states being told, hey, thanks for expanding Medicaid. We're not going to be covering 90% of your, Medicaid expansion. We're going to pare that down to 60 or 50% in order to buy ourselves a couple more years in solvency. And then these states are going to have billions of dollars of gaps that they're going to have to fill in some way. Was this article the one you actually got into the growth of healthcare costs in Texas's budget, or is that?
Yes, Texas healthcare spending. I tracked it from 2011 through 2019. It grew significantly, about 10%, roughly, and it continues to grow. And
so we have a roughly $200 billion budget here in Texas, right? It's more than that, but just for easy math. So about $200 billion budget. In 2011, about 18.5% of our budget was spent on health care, right? And
prior to the implementation of Obamacare.
Yep. And then today, that number is about 29%. So about closing in on a third of our budget overall is spent on healthcare within a very large Texas budget. And one would assume that if the federal government is currently covering a good chunk of that, 65, 66, whatever percent in Texas, that if it ever pulls back, that's going to only increase the burden on our state, and it could easily be in the 40s at some point in the near future.
Yeah, and one more aspect of this I want to touch on is there's a lot of questions that have been raised about whether Medicaid itself will yield a quality product in terms of the coverage. Now the care, you gotta separate those out. But in terms of the coverage, and there was an Oregon study that found there were statistically no difference in the people who were on Medicaid compared to people who were uninsured.
Yep. So and I saw that. So basically this took the same population within income and community and said there's a group of people here that are uninsured or not on Medicaid, and there's a group of here that are on Medicaid, and then let's follow these people and see if one of the populations is more healthy than the other population over a given period of time. And the conclusion was we're not seeing a healthier product, right? We're not seeing individuals on Medicaid be healthier than those people who are not covered by Medicaid. So when it comes to health care, not health insurance, not health coverage, but health care, there's really nothing that tells Texas, hey, if you get more people onto Medicaid, you're going to have a healthier society. People are going to be better off, right? So the second part of your three-part series is, the costs continue to increase and Texans seek better options. So let's kind of go into, this in general, but give us kind of an overview of this piece.
Large part of it is it's talking about the difference between the estimate-based pricing that the typical hospital system operates from. Compare that to more free market outfits that actually list on their websites the price you will pay. One thing that really jumped out to me was I looked up a hip replacement, and the average estimate. So it could range much higher, it could range a bit lower. But the average estimate for hospital hip replacement was around $40,000. And then at the Texas Free Market Surgery Center, it was half that.
Yep.
Now, the latter one does not use insurance. It's cash out of pocket. But also, if you don't have insurance and you purchase that, you're not paying a monthly premium or deductibles. So
this gets into kind of health care versus health insurance, right? So the way it works is if you have insurance, you walk into a hospital, you walk into a doctor's office, you get a set of procedures, you do those procedures, assuming they're going to charge X amount, and you really don't know what it's going to cost at the end of the day. They kind of estimate, you can call these people, you can figure that out.
Right.
And then you're going to get some bill. And then they're going to go to your insurance provider, or they're going to go to Medicaid, and they're going to negotiate payment for that, right? And they're going to receive payment of some sort. It might be what you actually got charged. It might be, more than likely, it's going to be 50%, 20%, 30%. I don't want to speak out of turn. I think I was being told by one person that, when we were talking about the rate at which the government pays these institutions, it's closer to 20 or 30%. Compared to private insurance. Yeah. And then private insurance is a little higher, 50, 60%, something.
And the way they decide that for Medicaid spending itself is they have this scaling system called MIPS. And doctors get graded essentially by the government, and they're incentivized to spend less time and money on their patients. That way they save the government money, and that gives them a higher grade, which then yields a higher return on Medicaid reimbursement.
Yep. That makes sense. And so, comparing that to a system in which you walk in and say, I want a hip replacement. I need a hip replacement for X, Y, and Z reasons. How much money can I pay you to receive said hip replacement? And they're going to go, well, we can do that for X amount of dollars, right? And so the difference between that interaction, which is how most goods are bought and sold in this nation, right? I mean, the vast majority of things you purchase, whether it's the car that you drive or even the house that you buy or all the goods at the market, is what are you charging? What are you charging? How much does this cost? Okay, I'm going to buy it here, right? And this is a huge chunk of the expenditures within our economy, within our society, but we really handle the purchase of this good very differently. And so the vast majority of these purchases are happening where I'm getting a service from you, you're charging set amount of money, and then you're going to negotiate. Honestly, I don't even know who you're going to negotiate with. I don't know the guy you're calling. I don't know the company. You're going to figure that out. Y'all are going to figure that out. And then I'm hoping that all gets covered. Right. And sometimes
that's
it will.
One part of it is the patient usually has no idea how much is actually being paid for the service that they're getting.
Yep.
And that creates an entire lack of transparency, which is something that these more free market outfits use, and that's what they base their entire model on.
You'd also have to say that if you're, let's look at this from the healthcare provider's perspective, right? If you know you're going to get covered, you're only going to get 30% or 40% or X% of what you charge. You're going to charge more, right? I mean, you're going to constantly charge more.
The
You're going to
insurance companies are incentivized to steer their clients to higher costing services.
Yep. And so, I mean, if you're the healthcare provider, you're going to say, look, I'm going to charge you $30,000 for this. Because the truth is, I know I'm only getting 30%, or I know best case scenario, I'm going to get 60% of these costs. So I'm not going to charge you $20,000, even if I think that's what you should spend, because I know I'm not going to call your insurance company and they're going to say, that seems reasonable. Here's a check for $20,000, right? So instead, I'm going to charge a higher number, knowing that I'm going to have to whittle this down.
Right.
The other thing, I didn't see this in your article, but I was looking at, I wasn't sure if you looked into any of the uncompensated care aspects of the reasons for high pricing. I don't know if you've looked into that at all. It'd probably be. And
you mean the amount that doctors don't receive from what they charge?
Correct. That actually gets So I mean, if I charge you $10,000 and Medicaid gives me $3,000, that other $7,000 gets considered within what we call uncompensated care, right? So you have counties, all these counties and these other places. We talk about uncompensated care a lot, that we have to write a bill for that. These hospitals or doctors, my understanding is that they have the ability to, not fully, but a portion of that also gets written off from a tax perspective, from an uncompensated care deal. So that's also going to drive and incentivize them to charge higher amounts, because I know you're only going to pay me 30%, but 30% of 10,000 is 3,000. And then that other 7,000 you don't pay me 40% or half or whatever, I get to now write off as uncompensated care, because I provided you $10,000 of care. I accepted 3,000 in payment from Medicaid, and the remainder I'll at least get some tax benefit from it. Right. And I'll get to tell people we provide X amount of uncompensated care to the community. And if I charged you actually what it cost, that number would be much lower. Right. So, so tell me about a little bit more just about some of the things that kind of came out of this issue. I know one of the points overall, because this piece got more into the drivers of the increase in healthcare costs in general, right?
Yes.
And that one of the main drivers with the Obamacare insurance regulation, the whole pre-existing condition mandate at the end of the day does cost us more.
Yes.
We know that that's likely the number one driver to the reason that people are paying a lot more in their premiums. Is that an overstated statement, or where am I?
No, I don't think so. I'm not sure exactly what proportion it would be, but it's certainly a significant one, especially since the government foots 90% of the expansion population costs, and if we are operating from the estimate-based system, that can go exponentially high. You have no idea. So yeah, I think you're right on that. One thing that a different point of view on it that I got was Medicaid expansion to some hospitals saved them a lot of money, because now they had people, instead of going to the emergency room, they would go through the normal route with Medicaid. That's not something to totally discount, but it's kind of it doesn't paint the whole picture, because of all the problems with Medicaid and all of the, back to the cost estimates, and then the limited amount of reimbursement. So that's one aspect of it that I found a different point of view on.
You did get into a little bit of the fact that in Louisiana, it looked like they had an issue when they audited their program where they had several people enrolled in Medicaid that got in that were making over $100,000 a year. So is there any basically meaning that within the expansion, sometimes the problem is that you actually get a bunch of people on this program that weren't supposed to be on the program? How is that something that other states have experienced the same problems, or is that kind of specific to Louisiana? Louisiana
was the worst of them,
really,
which is why it was so newsworthy. It resulted in 30,000 people being removed. Now, not all of them were making $100,000 a year, but that's a huge amount of people that should not be on the government roll that are costing the government a lot of money.
Yep. So we have the kind of insurance model of go consume the good, don't know what it costs, and then this other person who, you're paying Blue Cross Blue Shield, or you're a member of Medicaid, enrolled in Medicaid, but they're going to talk to somebody over there and they're going to figure out how to pay. Right. And then you have the balanced billing aspect. And why don't we talk a little bit about kind of how that works and what comes out of that?
Balanced bills are often surprise bills that show up at your door. And it's the difference between what the provider charges you, this is after the estimate, and what the insurance company permits based on your personal plan. And so you have to foot the bill for the difference. And there are a lot of states that are, I think Texas is one, that is seriously looking at balanced bill legislation. Because there are a lot of people receiving bills that they did not know were coming.
And then that kind of gets into quite a few people who have really advocated for this direct payment model,
Yes.
right? And that becoming
Yes.
kind of increasingly popular. In fact, I was kind of surprised by some of the different people that were actually, following this model. So what exactly are they calling that, and how does that model work?
The overall model is called direct patient care.
Okay.
And that can it can be surgery centers, it can be primary care, it can be specialists. And I talked to a few more people that are involved in that in my third piece on quality. But the entire idea is that we cut out the middleman, we clarify our prices, and not having this is another aspect that I talk about in my third piece, but not having the behemoth hospital system where they're increasingly reliant on data, where you basically, as they say, you become a barcode as a patient. So what these primary or these direct care facilities offer is clarity in pricing and more personalized care, more attention to the patients.
So basically with the direct care, now it sounded, from what you have in your piece here, it sounds like a lot of that's being used by employers, right, for their employees. And so essentially employers, instead of going the health insurance route, go the direct care route to say, hey, we're in this network, and you as employees, when you have healthcare needs, will go directly there. There will be an exact amount, and that will get paid by the employer.
Yes.
Right. And so the employer's paying as a...
Well, most of our system is employer-based.
Yes.
And that goes back to the Great Depression.
Yes.
And so it's not for the people using the direct care model are not just employers for their employees. There are a lot of families and individuals using it.
Yep.
But by and large, the biggest beneficiaries of it are the employers, because they are the ones that have these massive expenditures, which, as we mentioned earlier, the estimates can range so high.
Yes.
One barbecue place that switched in Texas saved between 30 and 50%.
Yeah. And was that Rudy's or was that something else?
Rudy's, yes.
I think that was Rudy's, right? So, no, I saw, Rudy's Barbecue in Lakeway. You know what's funny? It's like there's literally a Rudy's 100 yards from my living location. I go there for breakfast tacos sometimes in the morning. So yeah, I was a little surprised that they have shifted to this model as well. I know who was it I was talking to, but one friend of mine was telling me that there's several people that attribute the big employer shift that happened around the Great Depression to the wage caps that were put on during the New Deal, right?
Yes.
So basically you had, for the first time, and our nation really has never gone back to this, but for a period of time, you could not pay people more than X, right? And I believe that was in hopes of getting more people paid, right? Because you're like, everyone needs a job, so stop paying people X amount.
But the problem that comes with that is it was difficult to attract workers.
Correct.
And so what they did was started offering benefits, what we now know today as benefits.
Yes.
The main one being
healthcare. And so that was really the moment in time in which we had a shift within our system, where people prior to that had their own health insurance. And then all of a sudden these employers who were told by the government, you can't pay that guy more than X dollars an hour. Probably, I don't know, $3 an hour, whatever it was in the Great Depression. They go, okay, fine. Then if you come here, we'll pay for your health insurance. Because that doesn't count against us. And now we can attract the workers that we were trying to attract. And then all of a sudden this sets a little bit of a precedent that people start going, well, he'll pay my insurance. Are you going to pay my insurance? Yes. And even when the wage caps go away and people are allowed to get paid what they want, this idea that your employer is covering your health insurance has become a little bit of a norm.
Right. Yeah. Right. And the system before then was actually direct care. I mean, when you would have a family doctor come over to you whenever you needed them, usually they operated within a community. Nowadays, we're blessed with a lot of technology that can help doctors reach more people. This is a big thing in rural areas, the telemedicine. But one other aspect of hospital systems that causes a lot of prices to spike is something called anti-steering rules. And it goes back to insurance companies being incentivized because they're paid on commission to go to a place that has a higher rate. But at the same token, they're also disincentivized by this anti-steering rule from helping their clients find a lower cost alternative, because in the contracts they negotiate with the hospital, in it are these anti-steering rules which prohibit insurance companies from shopping around on behalf of their clients. And one woman I talked to, Cynthia Fisher, she pointed to an example of one of her clients. They negotiated a $7,000 birth, and the estimate she was given at a conventional hospital down the road was $42,000. That's just insane.
Yeah, as incredible. You'd have a hard time finding those discrepancies in any other area.
And part of that is part of the increase. There's different components to it. Part of it is the incentivization, but another part of it is the hospitals are so big, and they have to pay all these people to navigate the bureaucracy, the red tape, the regulations. That adds a lot of cost burden on them, and so they got to pay for it somehow. How do they do it? Distribute it to the consumer.
Yep. And so for these people that are just providing direct patient care, and this is kind of increasing in popularity, you have these companies that are saying, hey, just go directly to the doctor, pay him. We will pay directly to him, not through any insurance. And we've created a pool of people that all are going to get health care. So we now have access to these direct patient programs. Once you cut that out, that person doesn't have to have a staff of people that are just dealing with Medicaid and another staff of people that are dealing with reimbursements and negotiating with all these different insurance companies. And then all this paperwork to make sure that your MIPS or your PIPS or whatever is, high enough so that you're, getting a good enough grade. So you're getting the full maximum. None of that's cut out of the equation. Now you just have a healthcare provider providing direct healthcare to a patient and then billing that person a rate at which they're willing to pay.
Yeah, and just because it popped into my mind when you said it, MIPS, a woman, I think she's the head of the American Medical Association. She testified in front of the Senate and said that in order to get 100 on her, this was in my third piece, in order to get 100 on the score, she spent $100,000 more than she would have. And for an individual practice, that is a lot of money, and that goes back to that accumulated from her overtime for employees, navigating making sure all the regulations are kept to, and all this stuff. And on a smaller level, they just can't deal with it. And we're seeing a lot of this free market medicine is taking off because a lot of these individual practices just can't afford dealing with the regulations and trying to keep a good score on the MIPS.
So I want to just dig a little bit more into this steering, the anti-steering stuff. And so essentially what you're saying is it's an agreement between the insurance company and the healthcare providers. What is preventing the steering?
The hospital system's part of the contract.
Yes.
And I suppose it's a two-way contract because they each have provisions as part of the agreement that they prevent the insurance company from explicitly shopping around on behalf of their clients for lower costs services that would be a part of their plan.
Yes.
Does that make sense?
So basically, because you show up to a healthcare provider and he says, oh, we don't take that insurance, right? So they only take certain insurance.
Right.
And as part of their agreements with those different insurance companies, there's provisions that they have made sure that the insurance that send them patients, right? Let's say I only accept Blue Cross Blue Shield and X, Y, and Z. So if you're with Blue Cross Blue Shield, I have made Blue Cross Blue Shield in order to make sure that I take them, agree to not steering their patient and shopping and finding the best rate to send their patient to. So that can't be part of what the insurance companies do.
Correct. And on the flip side, the healthcare providers, the hospitals, doctors' offices that are all part of it, they are told you can only charge this much by the insurance company for a service. And usually it's an estimate. And so they're pretty high because they also take into account the commission that the insurance company wants to make and the profit that the hospital wants to make and that kind of thing. So it's a two-way street, and it's kind of self-fulfilling. They each have certain provisions in the contract that are steering clients to these high cost alternatives.
Yep.
Yep.
So the last piece you wrote, tell us a little bit about that piece.
So that was on healthcare quality. That was
Yep.
less data heavy.
Yep.
But there was some data in it. For example, this one's a very long piece. So last year in 2017, hospitals saw 880 million visits. And now that's not people. That's
Individual
people
visits.
Yes,
Yeah,
yes,
yeah.
people going multiple times. And that's a lot. So what hospitals have done is they focus on data. And the analogy I use is sabermetrics in baseball. They've kind of they've gotten rid of the personal human aspect of it, or much of it, as much as they can, and made patients into data producers. And they use that data to inform their procedures, what they should focus on, how much time they should spend on patients, what kind of medicine they should give them, that kind of thing. So I spoke to a few different people who have moved into this free market and non-third party, meaning they don't use insurance, model.
Yep.
The first one was Keith Smith, who runs the Oklahoma City, I think it's Surgery Center of Oklahoma, that's what it's called. But he also started the Free Market Medical Association.
Okay.
And he was the first guy, did it in 1997, first guy to really make a name for himself doing this.
Okay.
And it kind of got the ball rolling. They have, I think it was 25, 30 different chapters, and that's just in the States. There's numerous practices affiliated with each of those chapters. So they've gained quite a reputation and done pretty well for themselves. There's a lot of patients because of all the problems they've had in the common mainstream health insurance market.
Yep.
That are like yourself, just saying, I don't want anything to do with this.
Yep.
So one of the data sets that I saw that has driven people away, there's a 2018 study from Johns Hopkins that showed mortality rates. Hospitals with low mortality rates struggled with readmission rates. And so one aspect of that is they are not giving as much attention to the patient to prevent them from coming back in. Now, these are the top hospitals, the ones that you go to when you're sick and dying, when you have cancer. But they're seeing a significant spike in readmission rates because one of them is because they are just they're not prioritizing that as much because of this data-driven system. Another study that was done by Johns Hopkins suggested the third leading cause of death in 2016, and I think it has since been repeated, or at least close to that, was medical error. And what the free market advocates point to is that because you don't have the personal relationship with your clients as much, you're just reading off prompts on a screen, asking the client questions and plugging in the answers because it's all data driven. The overall quality is lessened, and it's hurt by the lack of personal touch from the doctors. A person I spoke to was Chris Held. She operates an ophthalmology practice in San Antonio.
Okay.
She's a big advocate of this. And she is the one who said she used to be in regular practice where she used insurance.
Yep.
She used Medicaid.
Yep.
It became too burdensome for her. And she actually had an experience herself as a patient that all of that together made her decide in 2015 she did not want to continue in this. And her experience as a patient was she had breast cancer. And while she was recovering from that, the meds they were giving her got mixed up. And when you check into a hospital, they give you a wristband. It's got a barcode on it, which is why she said you're
like
basically a barcode.
Yep.
But she was getting a much larger man's medicine, and so she almost died from that. And those are the medical errors that Johns Hopkins study highlights. Now, it's not to say that you're going to get third world country
we have an amazing
at
system.
a hospital. Yes. Places like MD Anderson in Houston.
Yep.
They're very good at what they do.
Yep.
But we're seeing a trend that is really creating this new market for high quality care at the lowest possible price, and that is what these free market advocates pride themselves on.
Well, this has been fascinating, and I really appreciate you being willing to come in. I know a lot of people, might not have taken the time to actually read all 3 of these articles. I'd encourage you to go to, the Texan and follow Brad. You can read all 3 of these articles that really draw out all of the numbers and explain this entire situation and some of these stories. It's going to be interesting because healthcare is going to continue to be a big discussion in Texas, right? It has been every session, but I think with it increasing in the size of what it takes as far as the share of our budget, it's only going to continue to increase in the conversations that we have.
And one thing to take away from it is money is not the only aspect of this. There are so many different facets to it that really addressing the issues that we see takes a lot more innovation than just putting money into it. And that is the case in education as well. But so healthcare is not the only one, but people really need to understand the issue better in order to vote for their politicians that actually understand the issue itself. Now that can be on either side, but it's such a complex topic, and that's why it's still so difficult to get these down to 3 2,000-word pieces. Which I'm sorry for people reading. I understand why people would not want to read that, but as a topic as complex as healthcare, you can't avoid it.
Well, I appreciate you being willing to put in the work to deliver 6,000 words of content on healthcare and at least give Texans the opportunity to go consume that information. Thank you for joining me today, Brad. I really appreciate your time. Thank you so much for watching this video through in its entirety. If you're somebody who's been following on with the conversations and the commentary that we've been producing here, we're going to ask you to do a couple quick things. Go to lukemacias.com. You can give us your email and sign up. We will email you new content, commentary, conversations as we produce it. Also, you can, if you're on Facebook or YouTube, you can like our page, follow our page, or subscribe to our YouTube channel. This will just continue to ensure that when we produce content, it gets to you more easily. Thank you so much for continuing to support the conversations we're producing. God bless you. God bless Texas.